I'm very pleased to announce the next speaker who has made a ripple in the Canadian landscape for endometriosis care, and that ripple has then continued into waves and tsunamis across the world. That is one of my favorite people, Dr. Catherine Allaire. She is a pioneer, I know she doesn't like to hear that part, in this space, and talking about advocacy, built at UBC a whole center for endometriosis and pelvic pain, and thereafter has taught many individuals across the country who have been able to really see the bigger picture, both for endometriosis, and I would say the even bigger issue is pelvic pain or chronic pain in general. So currently she's the director of the UBC Advanced Training Program in Pelvic Pain, Endometriosis, and Advanced Laparoscopy, is the medical director of the BC Women's Centre for Pelvic Pain and Endometriosis. She's collaborated in creating national guidelines with us and various different things, both guidelines that you saw presented today as well. She's been doing research and other things, but the most important thing is just before I became department head, I needed to just take some time off, and I got to visit her, and she was part of my own personal growth and knowing and really giving me the tools to succeed in my own career. So you're a friend, you're a mentor, you're an incredible individual and surgeon. Is that a nice intro or what? Okay, so come on up and do your talk.
Thank you, Sony. That was a lovely introduction. It was worth getting up at 4:30 in the morning for me. When Sony calls, I always say yes. So here I am. Thank you so much for the invitation. And I was tasked by Sony first to do approach to treating a patient with endometriosis. These are my disclosures, one of which is that we'll be talking about medications for endo, some of which are considered off-label. But they do have good evidence, and they are recommended in many guidelines, and there's no in-kind support for this other than a transportation support. And then the other disclosure is that after he asked me to prepare slides on approach to endometriosis, he says, oh, you're giving the talk on medical management of endo. So I'm like, okay, so now I've added a bit more about medical management within this talk, but really wanted to give you more of a context about the journey of endometriosis and its overall management. And also introduce a new tool that we've just are about to publish on guiding the use of surgery in the context of the management of endometriosis. So endometriosis, of course, mostly in the pelvis. We've talked about diagnosing it, about imaging it, but there's also a growing understanding that it's actually more of a systemic disease. And I love this paper by Hugh Taylor that talked about the impact of endo across the body, how there can be some metabolic changes in the liver, in the adipose tissue. There's some genetic upregulation of certain centers in the brain. And so really when we talk about endometriosis in this manner, we have to start thinking beyond surgery only, and that's why we have to have a different approach to this disease. And that's where medications have become something that we use in our tool set. Many guidelines have recognized that there's a role for hormonal management in endometriosis, so either as a first line or as part of a long-term management plan for endometriosis, because there's limitations to all of the approaches that we take, and because we want to have early approach and early treatment. So even ESHRE in 2022 came around to the Canadian way and saying that laparoscopy should no longer be a diagnostic gold standard and should also be part of postoperative medical management as a tool. This is our old template for endometriosis management, and certainly that will change with the next one, but it won't change dramatically in that we still have the idea that clinical diagnosis or suspected endometriosis is important. And we've heard beautifully today how imaging can help us diagnose certain subtypes of endometriosis, the deep, the endometrioma. But I want to remind you that those are only about 35% of patients. About 65% of patients will not have deep endometriosis, will not have endometriomas, will have only superficial peritoneal endometriosis, and therefore will not be really diagnosable until we get much better with imaging or have a non-invasive tool, unless we have a clinical suspicion. So they're going to get a clinical or suspected diagnosis in the office, And therefore, what do you do there? You certainly should start treating these patients, not waiting for an absolute diagnosis with laparoscopy. And that's why first-line management with medical suppression is very appropriate. And why is it we don't go to surgery right away with patients? Why is surgery not used routinely, and what is the limitations of surgery? Well, we do know that about 20 to 34% will have absolutely no improvement in symptoms, and that those that improve, about 22 to 30% is actually a placebo response. Actually, so it wants to be about half of that, so 60% improve, and the half of that is a placebo. There's a high recurrence rate of symptoms, so at 2 years, about 20 to 30%, and at 5 years, up to 50%. And we'll talk about recurrence of symptoms and why is that, and why is it that there's some people have no improvement at all. And that if you repeat surgeries in patients who have recurrence of symptoms with previous diagnosis of endometriosis, 32% will have actually no pathology. And no endometriosis recurrence. So what's going on with these patients? And you know, why is surgery so poor at treating some of these patients? I really like this. I'm a very visual learner, so I really like this chart that Chaperon published in 2019, because it really talks about how it's changing, how the landscape of treating endometriosis as a lifelong disease should be approached, and how the conversation can go in the office with, you know, how do we manage your goals, your quality of life? What do we do to keep this thing, you know, from affecting your quality of life? And the previous, you know, approach of, oh, you may have endo, let's do a laparoscopy to see. Oh, well, okay, now we've diagnosed endo, let's try some medication. Oh, well, that's not working, let's do another surgery, let's do another surgery and another surgery. And then when you're trying to get pregnant, maybe you'll need IVF down the road. To a more kind of holistic approach where you start with either a non-surgical diagnosis, you consider medical management with patients, and then at some point they may need a surgery, or they may go straight to fertility treatment if they need it, and then continue with medical management so that they're not, you know, destroyed, their life is not, you know, affected, their life course is not affected by endometriosis. And so this is what we want. We want people on the green line. We don't want people on that red line, because if we don't treat early, if we let patients go through these recurrent episodes of severe pain and ovulation pain, dysmenorrhea, deep dyspareunia, it affects their whole life. It also, you know, affects their relationships, it affects their ability to finish school, to pursue careers. It affects their nervous system. If they've had recurrent episodes of untreated pain, there's a windup of the nervous system that occurs, potentially, not in everybody, but in a certain subset of patients that might have genetic predisposition for it, that might have other trauma history that puts them at higher risk. Those patients, those susceptible patients, those are the ones that develop, you know, central sensitization, chronic pain. And if we treat them early, if we prevent these episodes of pain, we may prevent that windup of the nervous system. And that's why medical management is so important, and so important to do early. The other thing that we might also improve on is the infertility risks. We don't know if untreated endometriosis progresses and becomes more, you know, affecting of fertility. We think it does, and we're probably, you know, correct in that. So it's really important to treat early, and that's where medical management, you know, has a role. Now, I'm going to talk a little bit more about medical management and how do we do that, and what's the evidence for it. So we know, as Sony mentioned, that endometriosis is endometrial-like tissue. It has estrogen responsiveness. It has its own aromatase activity. It's very smart. It can make its own estrogen. It's pro-inflammatory and produces cytokines and other pro-inflammatory mediators. And there's relative progesterone resistance. And I get this question frequently from residents and all that, like, well, if it's progesterone resistant, how are you using progestins for it? So the progesterone resistance is at the physiologic level of progesterone, not at supraphysiologic doses that we use. So we can overcome that with some of the medications that we're using. But there may be some risk of failure because of that resistance. So the bottom line with hormonal managements is that they're all very similar in effectiveness. Really, if you're successful at suppressing menstruation, ovulation with the medication, about 60 to 80% of patients will respond. So they'll have improvement in their quality of life. It may not be pain-free, but they will say that there is an improvement. What's happening with the other, say, 30 to 40%? Well, we'll talk about that. There's definitely, we know we've already heard endometriosis pain is complex. People that don't get improvement, there might be other things going on that's causing some of their pain symptoms. And then a lot of the times patients are not well suppressed on medical management and are considered a failure, but really they've never been fully responsive to medical management. So of course we know that from the range of medications we have, there's different costs, there's different side effects, and different availability in different, in terms of coverage, et cetera. So we're all familiar with these, but I want to emphasize the progestins because that's probably the mainstay of what I use in my clinic, in my practice. We have a number of choices now, which is amazing. For many years, and he said, what did the word you use for me? I'm the pioneer, so that means I have gray hair and I've been around for a while. So as a pioneer, I was a user of medroxyprogesterone acetate for many years as the only really progestin that was available. I used it orally for patients. I found intramuscular quite full of side effects. Weight gain was a huge problem. You had to use it more frequently, every like 8 weeks instead of 12 for depo. So oral medroxyprogesterone acetate was actually, fairly successful, but I think side effects are still an issue. And then luckily Dynagest came to the market. Norethindrone acetate became available, and then drospirenone, the new progesterone-only birth control pill that's available and now free in Canada, is actually a game changer, and it's also been, very successful as a progestin for our patients. Of course, the IUDs are amazing for people that have just dysmenorrhea. And I haven't really used a lot of the implant, I think just partly because I don't do a lot of contraception, but patients that are on it, some do well, but there's a lot of breakthrough bleeding and ongoing spotting, which is an issue for people who have pain with their periods. So it may work, but ongoing bleeding can be an issue. Now, second line, you're all aware, you've all been familiar and used GnRH agonists, I'm sure, for many years. The most commonly one is leuprolide acetate. But the new players on the block you may or may not have as much comfort with, so I'll talk a little bit more about those. So GnRH antagonists, so we have the elagolix as well as the new rilugolix CT that have come to the market. And then the third line, which is interesting, is mentioned in a few guidelines, is letrozole, which in my practice I've used very seldom. I use it sometimes in postmenopausal patients that still have ongoing pain. I'm wondering if there's some peripheral conversion of estrogens, but it's mentioned, so I'll talk a little bit more about it there. Of course, costs and side effects vary, and you're all familiar with these. Basically, we know that the GnRH agonist antagonists, we're dealing with menopausal side effects, but they can be counteracted with use of add-back HRT. Why do I like progestins? Because they have multiple effects. Of course, if you do a higher level progestin, they can stop ovulation, stop menstruation, but they also have peripheral effect on implants of endometriosis. They can change the function of the endometriosis lesion. They can decrease inflammatory reaction, apoptosis, peripheral production of estrogens. So there's that central axis effectiveness, but also peripheral effectiveness. Again, lots of placebo-controlled trials showing efficacy, and also recent reviews looking at reducing endometrioma size and comparative to GnRH agonists showing equivalent effectiveness. So the agonists, again, very familiar with this, with GnRH agonists. You've been using it for a long time in your practice. Don't need to spend too much time on that. The only point I want to make is add back HRT. Please start it right at the initiate. If you're going to use an agonist, initiate HRT right away. Don't wait 6 months. Don't forget to prescribe it. And these are the combinations that you can use. You can use low-dose combined estrogen progestin, progestin pulsed, or progestins alone, especially norlutate, which is the one that's approved to use with leuprolide acetate. Do not use estrogen only unless the patient has no uterus. And do not use combined oral contraceptive pills. So I've seen that, and that dose is probably not appropriate as add-back therapy. And yes, we know that it does not diminish effectiveness and does definitely improve tolerability and side effects. So the new kids on the block. So the first one that came out a few years back is 4 years ago. It's about elagolix. It's an oral non-peptide receptor antagonist. So the difference between agonist and antagonist is you don't have that flare response that you can get with an agonist. You have basically immediate shutdown of the HPA axis. And of course, it's profound menopause if you use the twice a day, 200 milligrams twice a day, but if you use the 150, you actually don't have full suppression, and you can ovulate, so you have to be careful. Patients definitely have to use a contraceptive in addition. The data on it is quite good for dysmenorrhea, as expected, because it shuts down menses, so you would expect that it would help with dysmenorrhea. But you can see that the 200 BID is more effective than the 150 even for dysmenorrhea. Where it's not shining as much is in the non-menstrual pelvic pain. So non-menstrual pelvic pain, there is a statistically significant difference. However, clinically, I would say this is a very small difference. It's certainly more marked with the 200 BID, meaning the full suppression, than with the 150. Now, this is the Relugolix CT data. So at the bottom, you can see what's in the Relugolix CT. So it's Relugolix, which is, I guess, another antagonist, and plus estradiol and norethindrone acetate, all in one pill. So this is the latest kid that come to the block in the last year. It is convenient because it's a one tablet a day the patient takes and doesn't have to take AdVac separately, etc. So again, very good data on the impact on dysmenorrhea. So profound suppression, improvement in dysmenorrhea. And pain, actually, I think looking at this data, they weren't compared head to head, but it looks a bit more promising for than the pain domain for chronic pelvic pain as opposed to just dysmenorrhea. Again, all of us have very short-term experience with these medications because they've only been around for less than a year. And then the non-menstrual pelvic pain, actually this is the same thing. Again, the placebo versus Relugolix is not as promising. So we're looking at this one here, which is this one here is kind of not as promising, and I think that just goes to the complexity of pain with endometriosis. So suppressing the cycles, yes, you always get good response to dysmenorrhea, but the non-menstrual pelvic pain often is a more complex issue that needs to be addressed differently. And just quickly about aromatase inhibitors. This is the ESHRE statement, and I went and dug into those papers. I was surprised to see that as a strong recommendation, so I went and pulled the papers that they had used to recommend this, and there were like 40 patients, 30 patients. They're very poor papers, very small papers. And so, yes, you can use it, but you have to remember to use it in combination with other medications, or else you will have a flare, you'll have a superovulation impact, so you don't want that in these patients. And what about danazol? Those of us who are like pioneers like me have used to use danazol many years ago. I mean, even in my practice, it's never been a mainstay. By the time I started, it was not used a lot. But there is some papers in Japan, especially, where they've used a lot of vaginal danazol for large cul-de-sac nodules, and there's certainly some data on that. It's not great. It's not randomized in some of it, and they have a delivery system that they've created that we don't have. So in my practice, at times I have had a pharmacist make up danazol tablets, and the patient self-inserted that, and I've had a few patients who did really well with that, but I would say it's very anecdotal. But there's certainly certainly some Japanese data that's suggestive, but we don't have a good delivery system. I don't know. I want to find out from my colleagues if any of them are using vaginal danazol. No, we'll talk after. So one of the main issues with suppression, there's two main issues that you'll encounter when you're trying to suppress, well, many, but the two dominant ones that you'll encounter when trying to suppress a patient on give medical management, suppress ovulation menses, will be breakthrough bleeding and side effects. And the main side effects that I hear a lot about is moods. So you'll have moods and you'll have the breakthrough bleeding. So breakthrough bleeding to me is a little easier to deal with than the mood part, so we'll start with talking about that. If they're on like progestin suppression, my tricks are to do either double the dose if I think that I usually scan them in the office and I'll see if they're actually suppressed or not. I'll look at their endometrium and I'll look at their ovaries. And if there's a dominant follicle in their ovary, I know that they're not fully suppressed, and I suspect that the spotting and the bleeding is from a breakthrough type of ovulation, so then I will increase the dose of the progestin. However, if I see well-suppressed ovaries, really thin endometrium, sometimes I think it's actually from like atrophic endometrium, and I will do a short course of oral estrogen to try and stop the bleeding. If they're on an IUS, like a levonorgestrel IUS, breakthrough bleeding menstruation is quite common, and actually like ovulatory cysts are very common, and this is not a good situation for people who have ovulation pain. So I usually combine it with another medication, such as drospirenone or ethindrone, Dynagest, or even Elagolix 150. So this is a fantastic combination for endometriosis patients because you have the reliability of the IUD for contraception. You also have the local effect for the uterus, dysmenorrhea, adenomyosis. Those things do really well with IUD. But then you're also treating the ovulation and the breakthrough bleeding with additional medications. So the combos are really helpful. Of course, if they're on an HRT plus GnRH agonist antagonism, I'll stop the HRT and see if that's why they're having bleeding, and then kind of retailor the HRT. And sometimes they may have a terrible bleed from a flare. So, GnRH agonists, you should never initiate randomly, like in the middle of their cycle. If they're already suppressed on something else, you can initiate. But if they're not, there's two options. One is you wait for the luteal phase, like premenstrual time, to initiate, or if they're people they have randomly bleed or they don't know when their periods are or whatever, you initiate with letrozole for 5 days to prevent the flare. So these are all tricks to kind of prevent abnormal bleeding with medical management. Now, moods, I wish I had better solution. My usual trick to moods is if they're, a lot of patients, sometimes they come on a birth control pill or they haven't tried anything. That's pretty rare in our practice, but sometimes switching birth control pills, a different type of progestin may help with moods. Same with like the progestins that I'm on, I might switch to a different progestin to see if it's better for them, or completely different categories. So if they're really moody with adding hormones, sometimes subtracting hormones, putting them in a more low estrogenic state with that back will work better for them, especially if they say they have a lot of PMDD, PMS. That means that they're quite sensitive to the cycling and to the excessive hormones, and so putting them in that kind of stable, low hormone with add back can be quite good for them. Now, there's a bunch of medical therapies under investigation. I won't get into them, but there is some research being done. There is some pipeline of medications coming down the road, and hopefully, the panacea of medications would be something that has no impact on ovulation or menstruation, that people can get pregnant on and has minimal side effects. That would be the ideal drug, and so people are investigating targeting other aspects of endometriosis, impact on pain to see if they can get to that. So this comes back to the context of like the long-term management of endometriosis. We're going to have a great colleague this afternoon speak about surgery, so I'm not going to get into the details of how to operate and what surgeries to do, et cetera. But when to operate is a question that's already been brought up in all the talks, right? So who patients may really want an answer, and if they have the superficial peritoneal endo, you're giving them a clinical diagnosis but not a definitive diagnosis, and they may want to know if they have endo, and that could be definitely a legitimate reason to operate. There's certainly urgent issues such as, obstructive disease or concerning adnexal masses, which nobody will argue need to be treated, but the question is who should be doing that surgery. So again, if you know ahead of time there's deep disease causing bowel obstruction, ureteric narrowing, et cetera, you probably want them to be seen in a tertiary care center with the proper surgical skills to address that. So the patients that you might see in your office hopefully don't have any of those urgent issues, and if they have good imaging, you've ruled out deep disease. So they're the ones you're like, okay, they probably have superficial endometriosis, and here's the problem. They're not responding well to medical therapy, they're intolerant, they're not suppressed completely, they want to get pregnant, they can't be on medical therapy, and they also sometimes just want a diagnosis. So those are all times where you might discuss with the patient, and in collaboration with the patient, make a decision, together decide that surgery is the right thing to do. But if you're going to take them to surgery, please be prepared to treat and able and prepared to treat. So Jamie will talk about that later this afternoon, but they're probably going to have superficial endo, so you should be willing and able to treat that. Now, the patient I highlighted in blue is the one that has ongoing pain despite good suppression. Those are the 30% non-responders to medical management. Those are the ones that, what's going on with these patients. And it may be that you have a resistant lesion and they're still having pain from endometriosis, but most of the time you're going to find that it's probably a more complex problem you're dealing with. And so I know Ini is going to talk right after me about chronic pain and addressing that, but I just want to touch upon the fact that yes, endometriosis peripherally can cause inflammation, it can cause invasion, it can cause neurogenesis, but there's also a clear understanding that it can cause cross-sensitization with overlapping pain conditions. Chronic overlapping pain conditions is a NIH-recognized condition, and endometriosis is in there, along with irritable bowel, painful bladder, pelvic floor muscle, fibromyalgia. All those things can occur in these patients, and related to central sensitization as well. So it's a complex problem. It sounds overwhelming, but it's actually, when you have that understanding in that framework, it's actually not as overwhelming as a physician to kind of be able to try and assess all the different components. So that brings me to the Endometriosis Pain Index. So I don't know if you're familiar with the Endometriosis Fertility Index. It's a tool that was released 20 years ago, 25 years ago by Adamson. That's been validated as an excellent tool when you're operating on a patient and they want to get for endometriosis and they are trying to get pregnant. This tells you what's the chance after your surgery that they're going to get pregnant. It's a nice curve based on thousands of patients that he worked on and followed for pregnancy, and basically, this tool is been validated in many other centers as being very reliable. So when that was published years ago, I turned to my colleagues in the clinic, especially Paul Young, who's our research director, and I said, I want an EPI. Can we get an EPI? I want an Endometriosis Pain Index. I want a tool that our colleagues can use in the clinic and plug in whatever we discover are the factors that are predictive of pain outcomes, and tell the patient, a discussion tool, a management tool, and say, listen, based on this tool, I think that your chances of getting relief or improvement in your pain quality or your quality of life with surgery is this much. And it's not an all or nothing thing, because of course pregnancy is yes or no. Pregnancy is easy. It's like, did they get pregnant or not? But pain is a different thing. So, we had to decide, what are we going to consider a success surgery? So because we have a huge database, we have 6,000 patients in our database who have been followed for over 13 years. We now have enough data to extrapolate and see who had surgery, how did they do, and we've also very well phenotyped patients that have done multiple questionnaires, all been assessed in a very rigorous way with ultrasound and pain mapping. So we managed to really look at all the factors that we have collected and do, using the AI technology that's available now, be able to do basically using AI, trying to tease out who has, improvement in pain-related quality of life. And that was defined by using the HP30 score of over 75th percentile. HP30 is a standardized quality of life tool for endometriosis. So this basically would estimate the probability of poor outcome at 1 to 2 year follow-up after endometriosis surgery, using the machine learning model and clinical factors. And it's really a preoperative tool that can support pre-surgical counseling. And this is what it's going to look like. It's been submitted for publication, so I can't give you the actual publication yet, but we're hoping it'll be in a high-impact journal. And so you can see that the factors that actually, came out was actually what the age of the patient, some of the ethnicity, their BMI, and what surgery are you doing? Because we haven't talked about what surgery, but there's definitely good data out there that, hysterectomy is more successful than conservative surgery, but of course that's not a great option for a lot of patients. But so what surgery you're doing also impacts on the likelihood that they're going to have recurrence or improved quality of life. So keep your eyes out. I hope this will be something that would be an additional tool. And of course, we're going to have to validate this externally. We've only used it in our population, but we're hoping to see other centers, once it's published, kind of externally validated and see whether it's helpful to them, and we're very excited about this. So I'm just going to close with, the understanding that endometriosis, certainly, when you talk about endometriosis-associated pelvic pain, The one bubble is actual endometriosis and menstrual suppression and surgery, but there's many other bubbles that have to be addressed, and the core one is, central sensitization with pain education and other allied tools, mindfulness, physiotherapy, sleep restoration, mood treatments, and then, of course, the common comorbidities that we see in our clinic are irritable bowel, painful bladder, and myofascial pain. And even if you identify those, you're way ahead of the game. Like if you are able to do a few screening questionnaires that are readily available, and I'm sure Annie will talk a bit more about that, and identify those comorbidities and address them and treat them, you're going to be way far ahead of the curve with helping these patients. So I'm going to just summarize by saying that medical therapies are important, that hormonal therapies have equivalent efficacy but varying side effects. I really like the progestins. They have demonstrated benefit, and also a little bit cheaper, and kind of long-term use is easier. We have some new players in the table, the GnRH antagonists, and certainly you think about combining things, IUDs and additional medications. Surgery should be used judiciously, but certainly is something that we use in the right surgery at the right time with the right surgeon. The EPI tool may be something that could help you counsel patients, in your office, and that if there's persistent pelvic pain, despite, what you think were adequate surgeries, adequate medical therapies, then look for, evidence of central sensitization, chronic overlapping pain conditions, and approach those with a multimodal approach. So I'd like to acknowledge really our huge research team, our collaborators, our clinical team, all this work, and especially Paul Young, who's the medical research director in our clinic, who, none of our research would happen without his leadership, and take some questions. Thank you very much.
Thank you very much, Catherine. We've got online questions, and as well as in the audience here. And Paul is supposed to be here, but he's still sleeping, probably because of this time change. We appreciate
he may be flying in this morning.
Okay,
yeah.
okay. We appreciate your getting up early. So I'll start. I don't know who was first. I'll start on my right side here.
Hi, Laura Allen from Sarnia. I have a question I get from young women who want to have children one day but are not actively planning, maybe minimally symptomatic for whatever reason they found out they have endo, wanting to go on therapy for fertility preservation. What are your thoughts on that?
I guess the first question I have is, how do they find out they have endo? Do they have an endometrioma and ultrasound? Because that's one thing that's very specific, right? So I would say if they found out because they had an endometrioma and ultrasound but are minimally symptomatic from that, those are the types that I would probably suggest medical suppression, because we know it'll prevent growth of the cyst and, and potential further impact on their ovarian function, et cetera. If they were giving a clinical diagnosis and they're not symptomatic, that doesn't really jive with me. So if they're not having symptoms but we're told they have endo, I'm just not clear about how that would happen. So really you treat for symptoms generally. I mean, because the treatments can have side effects, can have other, kind of potential adverse effects on mood, et cetera. I don't think we have enough good data to show progression of endo. We've had a lot of data that shows that some endo can stay at the same stage for years, like minimal endo can stay minimal, and I've operated enough to see that, it was minimal 10 years ago, it's minimal still now, but then there have some that do progress, so it's hard to predict, but I don't think that most of us would treat an asymptomatic or minimally symptomatic patient for fertility prevention unless there's an endometrioma or deep disease like a bowel nodule or something. Yeah.
And I think, Catherine, just you may have mentioned this in your presentation. So I think we know that the OCP doesn't necessarily prevent progression of deep disease. So if you did have somebody who was younger, who had deep disease, doesn't want surgery, would you go more with the progestin? Because I feel as though...
Well, you're talking about the association of OCP use with deep disease, which is an association, not a causation. So I think, I don't know that we know it doesn't prevent, but I would say yes, progestins are probably safer. But if they're adolescents, then you want to use the higher dose OCP because of the bone concerns, et cetera. So I would say that, if the deep disease and LCP question is still up in the air. I don't know that we have an answer, but yeah, you're right. If they're in their 20s, then a progestin would probably be the first line for deep disease. If they have deep disease and endometriomas, yes, I would definitely use a progestin.
Perfect. Okay, so we have another question. Can I go to the one online first? Do you mind? Okay, perfect. So this is from Peter Watt, who's just mentioned, it's a very specific question, and actually I have not seen it myself. I knew there was a concern, so they've used GnRH antagonist alone, so elagolix, and had a liver function test elevation. And then he had to stop the treatment, and it resolved, but it was significant elevation. I don't routinely check the LFTs prior to starting GnRH antagonist. Your comments on that?
Same. I don't see that there's been in the studies that, because when they do these randomized control trials, they do test everything. They do liver functions. They do all the biochemistry on patients to make sure that there's no untoward effect. And I don't think anything's come out in these studies. So I would say that I certainly don't test, and I don't know what went on there. Yeah.
So the issue when we've done the research, as both of our centers do, we exclude anybody who even has a hint of issues. So that's why we won't pick up the real world experience. So I have asked Peter to let me know. We have to report this to AbbVie because there may be, we want to know more about it. But that's the issue with all the research. We exclude all the people who had any issues, who had central sensitization, who had chronic pain. We really focused on endometriosis patients, so the real world experience may not be the same. So I'll go over here. Just identify yourself and let me know where you're from.
So Losejo, Costa Rica. I was just wondering about progestins. We do have in Costa Rica a Drosby. Well, it recently came in, and we do have GnRH as well. How is your experience based on the two of them between like tolerance and acceptance, and which one would you recommend is like better?
What's the first one she mentioned? Sorry. What's the first one that you mentioned?
Drosby and GnRH.
Oh,
Drospirenone.
Yeah.
I'm sorry.
Okay.
Yeah, so the drospirenone, I think that the dosage is a little bit lower of the drospirenone, the birth control pill version. So I would say that the data on ovulation suppression is pretty good with it, but we have better data from GnRH. So it really depends on a few things. I think, with the age of the patient, the severity of their pain, what they've tried before, but I have been using it a lot as a first line kind of progestin for people who are quite reluctant as well for hormonal management. They're worried about side effects, et cetera. So I think the side effect profile is probably a little bit better with the drospirenone than probably because of dose effectiveness, yeah. Mm-hmm.
So thank you for being from Costa Rica. I wish I was in Costa Rica right now. So a couple of things about the GnRH that we had to follow up on as well. The adenomyosis SOGC guideline, it's an article or letter to the editor I haven't written back. If they have severe adenomyosis and heavy menstrual bleeding, GnRH isn't going to suppress the bleeding as well, and we have to be careful. So if you have somebody who's not doing well from the bleeding profile, think adenomyosis, and be careful of these big adenomyotic uteruses giving GnRH first line. Northindrone, on the other hand, which converts a little bit to estrogen as well, may be a better option as well. So Catherine, just following up on that question, am I totally off? Adenomyosis and GnRH alone?
Well, I think we have a lot of data again from Japan about GnRH and adenomyosis, but yes, is norethindrone better? I don't know that we have data saying that. So we don't have data looking at norethindrone and adenomyosis. It's a little different of a molecule, you're right. There's some peripheral conversion to estrogen, so maybe it'll affect things differently. But I can't say that I have seen papers that have compared that with adenomyosis, but I totally agree with what you're saying. So yes, in my breakthrough bleeding style, I should have mentioned look for adeno. But yes, if there's someone that's having ongoing, or polyps, endometrial polyps, other things can cause breakthrough bleeding other than hormones, obviously. If they had like pretty normal periods, not heavy, no intramenstrual bleeding, and you're trying to suppress them, and then they have all this breakthrough bleeding, that's why they go down the path I was outlining there. But if they had menorrhagia and intramenstrual bleeding before, then yeah, you have to rule out other pathologies that would cause that. Yes.
Okay. And next speaker, Professor Emeritus Nick Leyland.
Nick Leyland from McMaster University, and I'd rather be in Costa Rica as well. Having been there recently, it's a wonderful place, and obviously getting good clinicians. So my question really is to focus on, and you did a great presentation, Catherine, and I love your slides. The one slide that you had, central sensitization in the middle, endometriosis and the impacts that it has, and you also talked about preoperative predictability. So there are some studies on preoperative predictability for chronic pain after any surgery, and one of them is the issues of previous emotional, physical, mental, sexual trauma. So in terms of trauma-informed care, we need to be aware of all of that, and also to be able to have the ability to ask about these things in a very sensitive way. But in your model, are you using any of it, also anxiety, depression, these sorts of predictors? Are you utilizing that pre-surgery for your score, your index?
So what came out as statistically significant, definitely one of the mood predictors. I was just going to take a step back and saying, like, you know, over time, we've been doing these clinics for 14 years. So when we first started, the questionnaires we thought were going to be useful, you know, not always we're missing some. And as we evolve, we add questionnaires and take some away, because some we found were like kind of useless, and some we found, oh, we missed this. So for the CSI is a good example. CSI, the Central Sensitization Inventory, we started using routinely about 6 years ago. So when we did our predictor model, we didn't have enough data in CSI to incorporate it. And I'm like, but we have a paper that looked at CSI alone, and that's a predictor of poor outcomes. And like Matthew mentioned, over a score over 40, it was a predictor of poor outcome in surgery. So, you know, one of the discussion points in our paper is like, yeah, we're going to have to rerun this model in, you know, when we have enough data on CSI. Same thing with trauma. So we weren't using any kind of specific trauma. Well, we had some trauma questionnaires, but they were very generic, like asking about what trauma exposure they've had, you know, what they've been, and there's the better trauma questionnaires now that are out, and we're incorporating those. But to your point, you know, it's a very interesting question, the trauma question, and absolutely a lot of these patients have had various forms of trauma. And I talked about predisposition to chronic pain and how trauma can, you know, be one of the predisposing factors. But we have to make it generalized so that people can have, you know, of course, sexual trauma is the one people think about a lot, but any kind of trauma. And sometimes it can be medical trauma, honestly. We induce trauma in our patients by, you know, invalidating them, mistreating them, having them be called drug users, et cetera. So I think the trauma can be variable, but also the impact of trauma is also extremely variable in patients. And so our psychologist that was working with us for the chronic pelvic pain guidelines, she was very adamant that we make sure that we specify that it's active trauma symptoms, not just the occurrence of trauma, because first of all, there's that stigmatization that occurs with just looking for trauma and blaming everything on trauma, and that's a negative for patients. But also, the data doesn't seem to suggest that all patients that have trauma develop pain. So it's really more those that have unresolved trauma or active trauma symptoms that you have to identify. So that is, you know, I'm not a psychologist, and I'm looking forward to the talk this afternoon from our psychologist and see what her take on that is. But I've really tried to advocate for that in all like classification systems and diagnostic systems, because yeah, just kind of pinning it all on trauma. Yeah, like you have to recognize it, but I think the pendulum can swing pretty fast the other way, where you're just saying, oh, you were sexually abused, and you know that's why you're having all this pain, and you know, like, and so there's that kind of fine balance. But yeah, active trauma symptoms. So we have a new questionnaire that we're going to incorporate that's kind of more specific to that. Yeah.
That was a great summary, Catherine. So we have probably time for just quick questions. There's two speakers, or two questioners, so go ahead.
My name is Sagarika Basu. I'm working in Fargus in Ontario. Thank you for the great presentation. My question is there any maximum duration that you use the suppression for, especially for GnRH analogs, antagonists, and Dynagest?
So the Dynagest has no Health Canada limitation on duration of use. The GnRH antagonists do. They are limited to 1 year at the moment based on Health Canada approval. As you all know, we use medications off-label and beyond approval many, many times. So I would say that GnRH agonists, the leuprolide acetate, I have lots of experience for using that way beyond a year with add-back HRT. And there are some published case series, some from one of my colleagues, Dr. Badawi, of 10 years of use with bone density being well preserved. The caveat I would say is that there's good studies showing that if you're going to use beyond a year, like the standard norlutate is not good enough. You need to add estrogen, so a low dose of estrogen as well. So norlutate alone is okay if you're going to use it for 6 months, a year, or whatever. But if you're like, this is working great, she wants to stay on this, she doesn't want surgery, she has bad endo, she needs to stay on this, add estrase. Add a dose of estrase to protect her bones, because there's an RCT that compared the two, and the estrase group had better bones, yeah.
And if you are using it for long term, would you then consider bone mineral density or just add back?
Yeah, I think it's reasonable to do it. It depends on the age of the patient too. So the BMD in younger patients is kind of, they always give you like, well, we don't have standards, she's too young, et cetera. But if I'm using it for long term, I will do the odd, once at baseline to make sure that I'm not already starting really low, and then maybe once in like 4 or 5 years to make sure it's stable. And if there's that stability, I probably won't do it frequently after that, yeah.
Thank you.
So because of time, do you want to go ahead and ask your quick question? I might just defer the answer to a panel, but we'll see.
Yeah, that's no problem. Hi, I'm Julie Thorne. I'm an OBGYN here in Toronto. Thank
hi.
you. And maybe I'm going to say them quickly. If they're not quick questions, happy to defer them. One of my questions was around Alagalix, and maybe that around the long-term use and thoughts on bone mineral density if they're on the 150 versus the 200 BID. And if you could speak to your experience on like doing 200 milligrams once daily, because I have a lot of patients who start to like self-manage their own medications. And then Dienogest, are you using it continuous and skipping the like 4 days of hormone-free interval, or are you using it as it is in the package? And then could you speak to kind of how you employ, or if you still are, the anti-inflammatory diet? I kind of noticed it had a line in the IBS. I give your handout all the time, and I'm a bit of a subscriber to some of the like pro-inflammatory features of diet in our processed foods and our highly processed sugars, and so I'm just curious if you could speak to that.
So,
that's maybe a longer question.
No, they're great questions, so I will leave it to the panel just because of
Sure,
time, because Indy's
absolutely.
next. But they're all like great questions, and that's why we've got the panel discussion. So
yeah,
go for it.
we'll-
So thank you so
Okay,
much,
thank
Dr.
you.
Allaire. Perfect.